Case 3 T2D patient with muffled MASH slide 1, titled Good Morning Afternoon Everyone. I am Dr. Ashutosh Mishra, and today I will walk you through a very clinically relevant case, a type 2 diabetic patient who presents with metabolic dysfunction-associated fatty liver disease, or MASLD. Over the next 15 minutes, we will journey from diagnosis to risk stratification to therapeutic decision-making with a focus on the latest evidence. Slide 2, meet Aman. Let me introduce you to Aman, a 55-year-old gentleman who comes to our attention not through symptoms, but through a routine blood test at his workplace. He has had type 2 diabetes for 8 years, currently on oral antidiabetics with an HbA1c of 7.9%, so glycemic control is suboptimal. He is also on a statin for dyslipidemia. His BMI is 34.6, placing him firmly in the obese category. He has attempted lifestyle modification for weight loss, but with only modest success. Now look at his LFTs. ALT is within normal range at 21 IUL, but his AST is elevated at 45 IUL. This is a critical observation. A normal ALT does not rule out significant liver disease. His platelets are normal at 193. This apparently mild derangement in a high-risk metabolic patient demands thorough investigation. Slide 3, ADA Diagnostic Algorithm Overview. So how do we approach this? The ADA 2026 Standards of Care give us a very structured diagnostic algorithm for MASLD, metabolic dysfunction-associated steatotic liver disease. The 3 highest risk groups for future cirrhosis are patients with type 2 diabetes, prediabetes, and obesity with at least one cardiovascular risk factor. Aman ticks all these boxes. The first step is to rule out secondary causes of steatosis or elevated ALT. Once done, we apply the FIB for index, a simple, non-invasive, validated tool. If FIB is below 1.3, the patient is at lower risk for future cirrhosis and can be managed in primary care with repeat FIB for every 1-2 years and lifestyle optimization. If FIB4 is 1.3 or above, we move to the next step, liver stiffness measurement or LSM, preferably by FibroScan. If LSM is below 8 kilopascals, primary care continues, but if LSM is 8 kilopascals or above, or if FIB4 is greater than 2.67, the patient should be referred to a liver specialist for advanced imaging, biomarker risk stratification, and treatment. Slide 4, FIB for calculation for Aman. Let us now apply this to Aman. The FIB4 formula uses age, AST, platelet count, and the square root of ALT. For Aman, age 55, AST 45, divided by platelets 193 or 21, this gives a FIB4 score of 2.8. A score below 1.3 is low probability of advanced fibrosis. Between 1.3 and 2.67 is indeterminate, the gray zone. Above 2.67 is high probability of F3, F4 fibrosis. Aman's FIB4 of 2.8 places him in the high probability zone. This is alarming and mandates referral and further evaluation. The ORAC of FIB4 for advanced fibrosis is 0.79. It is a robust and widely validated enrichment biomarker. Slide 5, next step, FibroScan following the algorithm. Since Aman's FIB4 is above 2.67, we move directly to liver specialist management. But we also proceed with transient elastography, i.e. FibroScan, to quantify liver stiffness. This takes us to the next question, is his LSM above or below 8 kilopascals? Given his FIB4 of 2.8, we expect significant fibrosis. Let us see what FibroScan reveals. Slide 6, FibroScan results and role of transient elastography. Transient elastography is a bedside, non-invasive tool that gives instant results with good accuracy. Its limitations are cost and availability, but where accessible, it is the preferred modality. Aman's FibroScan result is 12.4 kilopascals, sitting right in the gray zone between 8 and 15 kilopascals. The sensitivity for F0, F2 fibrosis at 8 kilopascals cutoff is 93%, NPV 90%. For F3, F4 at 12 kilopascals cutoff, specificity is 88%, PPV 67%. At 15 kilopascals, the PPV for advanced fibrosis is 75%. Aman is at 12.4. This is moderate to advanced fibrosis territory, warranting liver biopsy for histological confirmation. Slide 7, results of Aman's investigations, diagnosis of MASH, pulling together all findings, FIB4 of 2. 8. CI on elastography of 311 dBm confirming significant steatosis, LSM of 12.4 kilopascals indicating moderate to advanced fibrosis. Liver biopsy was performed. Histology confirmed fibrosis stage 3, F3. So Aman's diagnosis is now confirmed: MASH, metabolic dysfunction associated steatohepatitis with advanced fibrosis. This is a patient at high risk of progression to cirrhosis and its complications. The clock is ticking and we must act. Slide 8, let us discuss treatment goals. We now face 4 critical treatment goals for Aman: fibrosis improvement, MASH resolution, prevention of downstream outcomes, cirrhosis, liver failure, liver cancer, and future direction. Which pharmacological agents best achieve all of this? Let us focus on the most evidence-backed answer. Slide 9, ADA 2026, semaglutide 2.4 milligrams preferred in MASH. The ADA Standards of Care for Obesity 2026 provide a disease state-based algorithm for selecting obesity medications. When the comorbidity is MASH, semaglutide 2.4 milligrams has demonstrated benefit. It is the only agent with level A evidence for MASH benefit in this framework. Tirzepatide shows potential benefit at level B. Liraglutide is potential at level C. For Aman, who also has TT2D, dyslipidemia, and obesity, semaglutide 2.4 milligrams addresses multiple disease dimensions simultaneously: glycemia, weight, lipids, cardiovascular risk, and now, crucially, the liver. Slide 10, the ESSENCE trial. The landmark evidence comes from the ESSENCE trial, a phase 3 randomized double-blind placebo-controlled study conducted across 37 countries with 1,197 participants, randomized 2:1 to semaglutide 2.4 milligrams once weekly versus placebo. Part 1 ran for 72 weeks with the primary endpoint of improved liver histology. Part 2 is event-driven at 240 weeks, assessing liver-related clinical outcomes. The trial enrolled patients with confirmed MASH and F2 or F3 fibrosis, exactly Aman's profile. One important regulatory note: semaglutide 2.4 milligrams is FDA approved for MASH treatment in adults, but is not yet approved for this indication in India. Slide 11, ESSENCE, 63% MASH resolution. The ESSENCE results are compelling. In Part 1, at 72 weeks, 62.9% of patients on semaglutide achieved resolution of steatohepatitis with no worsening of liver fibrosis, compared to only 34.3% in the placebo group. The estimated difference in proportions is 28.7 percentage points, with a 95% CI of 21.1 to 36.2 and p less than 0.001. This is a highly statistically significant and clinically meaningful result. Nearly 2/3 of patients on semaglutide achieved MASH resolution. Slide 12, ESSENCE, 37% fibrosis improvement. Equally important is fibrosis improvement. 36.8% of patients on semaglutide showed improvement in liver fibrosis with no worsening of steatohepatitis, compared to 22.4% on placebo. The EDP is 14.4 percentage points, again highly significant at p less than 0.001. For Aman with F3 fibrosis, a 37% chance of fibrosis improvement represents a real opportunity to prevent progression to cirrhosis. Slide 13, 2x dual benefit. Most impressively, patients on semaglutide 2.4 milligrams were twice as likely to achieve both MASH resolution and fibrosis improvement simultaneously, 32.7% versus 16.1% in the placebo group, with an EDP of 16.5 percentage points. This dual histological benefit is what we are looking for in a patient like Aman, where both inflammation and fibrosis need to be addressed. Slide 14, holistic cardiometabolic benefits beyond the liver. Semaglutide 2.4 milligrams achieves a comprehensive cardiometabolic profile that is unmatched by any other single agent. In terms of hepatitis, MASH resolution, reduced disease activity, halting of fibrosis progression, and improved fibrosis are all demonstrated. In terms of cardiometabolic targets, significant body weight reduction, improved lipid profile, improved glycemic control, and improved cardiovascular parameters. All of these converge to deliver improved long-term clinical outcomes. For a patient like Aman with T2D, obesity, dyslipidemia, and now confirmed MASH F3, this is a genuinely holistic therapeutic solution. Slide 15, key takeaways to summarize the key messages from Aman's case. First, semaglutide 2. 4 milligrams is now FDA approved for MASH with moderate to advanced fibrosis, irrespective of BMI and diabetes status. Second, in the Essence trial, it delivered 63% MASH resolution and 37% improvement in fibrosis. Third, twice as many patients on semaglutide achieved the dual endpoint of both fibrosis improvement and MASH resolution compared to placebo. The message for our clinical practice: in any patient with T2D, obesity, and elevated liver enzymes, screen proactively using FIB4 confirmed with FibroScan, and if MASH with significant fibrosis is confirmed, place semaglutide 2.4 milligrams at the center of your therapeutic strategy. Thank you. I am happy to take any questions.